Lung cancer is one of the leading causes of cancer-related deaths for both men and women, and it commonly occurs between the ages of 45 to 70. The prognosis of lung cancer is poor because it's usually diagnosed at an advanced stage when metastases has already occurred. Palliative care or treatment geared towards relieving symptoms is often the focus in advanced stages. Bronchogenic carcinomas that arise from the bronchial epithelium account for about 90% of primary lung cancers. And the histologic cell types determines lung cancer classifications, and those include the non-small cell lung cancer. Most lung cancers are in this category, and they include squamous, adeno, and large cell carcinomas. The small cell cancer is another classification, and it is fast growing, and it's almost always associated with cigarette smoking. Staging of the lung cancer is defined by the TMN system, T for tumor, N for nodes, and M for metastases. And the next slide shows the breakdown of that quite well. It's also covered very well in your text. Chemotherapy is a primary choice of treatment for lung cancers, and it's often used in combination with radiation and surgery. So with cancer, you either cut it out, poison it, or burn it. Cut it out with surgery, poison it with chemo, burn it with radiation. So if it's caught at all early by any chance, they will take it out and cut it out. Our risk factors definitely are smoking, any type of radiation exposure. Once again, we want to make sure that we have our patients who are at risk and work in an environment or have hobbies that have known carcinogens will protect themselves. The cigarette smoking, both first and secondhand smoke. Patients can have lung cancer and never have smoked themselves, but perhaps lived with the smoker. Radiation exposure, did I put that up there? Yes, I did. Older adults have an decreased pulmonary reserve because of the normal lung changes. That includes decreased lung elasticity and thickening alveoli, and that will impair their gas exchange as well and put them at risk. So what kind of... next slide. Okay, this slide I put up here to talk about the staging of non-small cell lung cancer, but it's a nice explanation of the TNM system, and I'm not going to read through all this. You can have a look at this. It's also outlined very well in IGGI. Okay, the signs and symptoms of lung cancer. Few early symptoms. Often patients, smoker's cough. They smoked forever, they have smoker's cough, so they put off that change. But it's a persistent chronic cough with or without hemoptysis, and that would be rust-colored or blood-tinged sputum. They may have hoarseness, which they also may put off to their cigarette smoking. Dyspnea. There may be unilateral wheezing if there is an obstruction in the airway. They may have chest wall pain. They may have chest wall masses that you can actually palpate. Muffled heart tones. Fatigue, weight loss, anorexia, finger clubbing as well. Diagnosis, chest x-ray and CT scan. They're looking for initial identification of the tumor, and then they may go and have a bronchoscopy to get a specimen for it. Okay, so care. What do? We want to check their history regarding their tobacco use, their pack year history, evaluate any other tobacco products like cigars, pipes, chew, secondhand smoke exposure. We want to talk about their cough and any changes in the pattern. We want to look at their nutritional status, any weight loss and anorexia, and therefore we're going to promote adequate nutrition and their need for calories because they're going to work harder to breathe. We want soft, high caloric foods and make sure they're hydrated. We're going to watch their airway, give them suction if they need to, high Fowlers for maximum ventilation. We're going to look at their limitations and give them periods of rest, cluster their care together, emotional support for the patient and family, encourage them to verbalize their feelings. We're going to discuss the topic of death and dying with the client if their cancer is terminal and encourage them to express their feelings. They may actually have a fever as well. I didn't mention that, but they might have a fever with this. They have an inflammatory process. Okay, medications. Chemotherapy is the treatment of choice typically if they treatment of choice is chemo. And the purpose of that medication is to destroy the cancer cells as well. It also destroys the healthy cells. And what we're trying to do is to prevent DNA formation in the cancer cells. So platinum compounds such as cisplatin is commonly used. So if we have them on chemo, we're going to be watching for decreased immunity, nausea, vomiting, fatigue, shortness of breath. We're going to look for sores in their mouths. We're going to teach them to let us know if any of that happens. We're going to give them oral hygiene, soft toothbrush, avoid any alcohol-based mouthwashes, so no Listerine. And then we're going to talk about alopecia that usually occurs about 7 to 10 days after they start their chemo and how they want to deal with that. It's a big deal to many patients losing their hair. Opioids, we're going to give them pain medication. MS-Contin, OxyContin, fentanyl. We use that to treat moderate to severe pain caused by their illness. And use with caution with patients who have asthma and emphysema because we don't want to respiratory depress them. We're going to assess their pain every 4 hours. Watch for signs of respiratory depression. We're going to use their pain medication around the clock. And watch for any nausea and vomiting, and all opioids decrease gastric motility, so we're going to manage their constipation with that as well. Okay, so let's talk about the surgical interventions that they use for lung cancer. The goal is to remove all the tumors, so all the tumor cells, so that can include the lymph nodes as well. Removal of the entire lung, which is called a pneumonectomy. If they take out a lobe, that's called a lobectomy. A segment, which is a segmentectomy, or a peripheral lung tissue, which is a wedge resection. These patients, obviously surgery, so they need to have a consent prior to going in. You're going to teach them preoperatively about if they're going to have a chest tube or not, and how to splint their chest. Deep breathing, coughing is so very, very important. They're going to have pain medications, that they may wake up on a ventilator, and that type of thing. So we're going to teach them about their procedure and the chest tube placement. And we're going to relieve their anxiety, encourage verbalization of feelings, etc. Once they get home, we're going to talk about set up any referrals they need at home, home health, hospice, respiratory services, portable O2 program, delivery, that kind of thing. any outreach programs, food delivery services, that type of thing. Now, I want to talk a little bit about these surgical procedures. Patients who have a pneumonectomy, they will come back without a chest tube in place. And if they have a lobectomy, segmentectomy, or wedge resection, they will have a chest tube. I want to make sure that you watch the videos on chest tube that are streamed for you on Blackboard, and you will also see one in class. These are important for you to watch, and there is a great article on Blackboard about chest tubes as well. So, pictures of lobectomy and pneumonectomy are here. I am going to cover this a little bit more in subsequent slides. And this is that subsequent slide I was talking about. I have dragged this chart around for many years, but I quite like it. A lobectomy, it's removal of one lung. See this in cancer. It is the most common surgery. They will have up to 2 chest tubes in place. A pneumonectomy, that's where they take out the entire lung. They will come back, and if they will not have chest tubes, so there's no drainage tubes in place. And the segmental resection wedge, all that stuff is in there as well. I like this chart a lot because it tells you what it's indicated for, what the procedure is, and whether or not they're going to have chest tubes. So I like you to have a look at this one. It's important to know that. Okay, so nursing care, I went over that a little bit earlier, but we're going to teach them preoperatively: deep breathing, coughing, IS, patient-controlled anesthesia, chest tubes, they need to get up, moving right away, post-operative exercises that we're going to look. Post-operatively, we're going to do their vital signs and pain management, and how to prevent complications. There's a nice little thing here about that. Chest tube management with radiation as that other form of treatment for lung cancer. Esophagitis is common for that, so we're going to have dietary considerations. Possibly they'll be on steroids for the pneumonitis, and then chemotherapy. I went over that a little bit earlier. Complications of lung cancer can be a superior vena cava syndrome. That results from pressure placed on the vena cava by the tumor. It's a medical emergency if that helps. If that occurs, not helps, if it occurs. We're going to look for signs, which would include facial edema, edema in the neck, nosebleeds, peripheral edema, and dyspnea. Late signs of superior vena cava syndrome are altered mental status, cyanosis, hemorrhage, and hypotension. This is an emergency, so we notify the physician immediately. They may put a stent in to relieve pressure, and they may use radiation to try and take that pressure off the vena cava. Second complication of lung cancer is metastases, and typically to the bone, so they have bone pain. They have increased risk of pathologic fractures. If they have metastases to the central nervous system, we can see a change in mentation. They become lethargic. They could have bowel and bladder malfunction. It's a nasty disease.